So it gives us immense pleasure to welcome Dr. Anne Wyllie to our seminar series today. Anne is an associate research scientist in epidemiology in the lab of Dr. Daniel Weinberger at the Yale School of Medicine. And today she's going to talk to us about her recent findings on the SARS-CoV-2 virus.
Thank you. So I'll just get the slides up. So yes, thanks for having me this afternoon. I would like to just share our work that we've been doing on in which we've actually found saliva as a viable sample type for SARS-CoV-2 detection. So the current gold standard for the detection of upper respiratory tract pathogens is the nasopharyngeal swab. This is what's often already used in a lot of sort of viral panels. It's used in a lot of carriage and surveillance studies, and it does a good job at detecting upper respiratory tract pathogens. One of the downsides to it, however, is that I'm not sure how many people out there have actually had the joy of experiencing one during the season so far, but they can be very uncomfortable. They can also lead to irritation, which also means that whoever's having that swab taken, they might be led to sort of like cough or sneeze, and this puts the healthcare worker at risk of infection as well. Another common method is the oropharyngeal swab. This is more tolerable, though it can also lead to irritation. And actually oropharyngeal, so bring this back obviously to COVID, oropharyngeal sampling was it was looked at originally during the outbreak, often with the paired nasopharyngeal swabs. This was soon, however, dropped because of all of the supply chain issues that we were facing with the as the outbreak continued. So originally, the CDC recommendations for COVID diagnostics testing was the collecting and testing of upper respiratory tract specimens, specifically the nasopharyngeal swabs. However, this report came out quite early on in the outbreak published in CID, where they just looked at 12 COVID patients. They took self-collected saliva from them, and they looked at the viral load over time during the course of hospitalization of these patients. And they actually found that they suggested very early on that saliva could be a promising non-invasive specimen for diagnostics, monitoring, and infection control in COVID-19 patients. However, what was really missing from this report was actually a direct comparison to nasopharyngeal swabs. But going on from this, some of the potential of saliva sampling already was that other studies have already shown that saliva may have up to 90% or over 90% concordance with nasopharyngeal swabs for detecting respiratory tract viruses or other pathogens, also including already coronaviruses. One of the great benefits about using saliva is that healthcare workers are not required to collect the saliva specimens. So this really reduces the risk of nosocomial transmission. It can also really help by eliminating waiting time for specimen collection. So rather than having to rely on your healthcare worker to go around, collect all these samples individually, you can really just sort of hand these collection pots or little cups or tubes, whatever you have, out to individuals, ask them to self-collect their saliva and sort of just hand them back. This can also just really greatly improve turnaround time for test results, and as you can imagine would be very important in either busy clinical settings, so in hospitals who are under pressure sort of responding to outbreaks, or even you may have all seen the sort of different drive-through testing stations. Instead of having to rely on a very limited number of available staff, you could really alleviate that by handing collection cups out to individuals, asking them to take their own samples. So it is a very practical choice for efficiently screening a large number of individuals, and you don't really need any sort of real important considerations. You don't have to really think about having very specialized rooms for this. You can just take these out in the community, do them in outpatient clinics. It could also be it would hold potential, as they sort of showed in the paper in CID, for serial viral load monitoring. So once you have someone who is in the hospital, or if you're just wanting to just sort of study the course of infection, it's very easy to collect then repeated samples from individuals. So instead of, sampling, giving someone a nasopharyngeal swab every day or two, you know, a self-collected saliva sample has a lot less discomfort to the patient, it has a lot less risk to the healthcare workers, and so, you know, really, you know, saliva did really already hold a lot of potential as a sample type, but just not really much was sort of known about that. So when all this happened, I mean, it's just been, what, 12 weeks ago that we really sort of got into this all, I think 12 weeks now. So here at Yale, we actually started a biorepository. This is now called the Impact Biorepository for implementing medical and public health action against coronavirus. So for this, what we were doing is we were enrolling some different study cohorts. So we have an inpatient cohort and we have a asymptomatic healthcare cohort, healthcare worker cohort, where we're sort of just been collecting an array of samples. And the idea with this was that we were able to sort of respond to the outbreak that was going on, but also build up a biorepository of samples from this, you know, this novel coronavirus that was appearing, just so that we could build this really great resource for research, not only here at Yale, but throughout the wider medical and academic community. So what we first started doing is we were initially looking at the COVID-19 inpatients. So these are hospitalized patients that, you know, there were people who were presenting with sort of COVID-like illness. They presented at the hospital and they had a confirmatory COVID-19 test. And this was through any of the potential sample types, whether it was a nasopharyngeal sample, oropharyngeal sample, or even sputum. They were enrolled into the study if they were over 18 years of age and they signed informed consent. Consent was gained on day 0, and then on day 1, a whole array of samples were collected from them, being nasopharyngeal swab, saliva, blood, urine, rectal swab, and this would repeat every 3 days throughout the course of their hospitalization. So already we were in quite a unique setting where saliva was already one of the samples that was just in this sort of myriad of, you know, sample types that we'd listed to collect, and that's because saliva is just such an easy sample to collect. It, you know, doesn't require, you know, I've just been through that, just the lack of requirements on healthcare workers, the lack of sort of, you know, you don't need sort of specialized collection material for that. So much so that the patients, you know, the little container was just left in their room next to their bed, and they were just simply asked as soon as they woke up that morning, before they ate or drank, if they could just spit into this cup for us and we could collect that. So the other arm I also mentioned was the healthcare workers. So these are asymptomatic healthcare workers who are working at Yale New Haven Hospital, so on COVID-19 wards, or may have other COVID-19 occupational exposure. So with this cohort, it was really to act as an active screening mechanism to sort of help prevent any transmission in the workplace. So again, these individuals would sign up for the study on day 0. They were consented. We got an initial blood draw from them, and then every 3 days we would take, well, actually we wouldn't take anything from them. They actually provided a self-administered nasopharyngeal swab, so they were swabbing themselves and also just providing a self-collected saliva sample at each of the time points. And this is, I mean, this is a study overview from a little bit earlier on. Originally we were only going to follow them for 14 days. It got expanded to 28 days, and I believe what I heard this morning is it's now up to about 84 days. So this is just a really ongoing screening of these healthcare workers, making sure that they are you know, well and healthy and safe to have, you know, sort of working in the hospitals. So what we were doing here as well is that if any sample happened to come back positive, this actually flagged them for a clear screening, so a clear diagnostic test. So they would have to go and have an official nasopharyngeal swab tested in a clear diagnostic laboratory, and then based on that diagnosis, we could sort of inform decisions, and if this person was positive, so sort of what we would do after that. So this is just an overview of our workflow. So we have the sample collection. You know, we're receiving into the biorepository, you know, hundreds of samples per day. These will have to be all aliquoted out at different aliquot volumes, different tubes, just for different purposes. they come to us and we do the RNA extraction from them, and then they get sent to another lab, Hikowasaki's lab, for RT-PCR detection. So already this has been a very, even just this little part of it is a massive team effort between different labs and, you know, a huge team of people. But even, you know, it was within the first week that we sort of started realizing just all the issues that would crop up with this. And our very first one that we suddenly had to deal with was, even within about the first week or two of the biorepository running, was the supply chain issues which were being faced all around the country. Basically was the shortages of not only PPE, but also the nasopharyngeal swabs. So, you know, word came out very early on that the nasopharyngeal swabs were in short supply. It didn't particularly, of course, help that Copan, who was one of the #1, you know, they're one of the biggest manufacturers of nasopharyngeal swabs. Copan, they're based in Italy. So, of course, Italy was facing sort of the peak of their outbreak just before us here in the US. So, you know, their supply chains there had been greatly affected by their outbreak, having to get the swabs here, which, you know, it didn't help that, of course, you know, I think we all saw this coming. You watched it unfold, and so those who had swabs were sort of holding on to it. Those who could prepare sort of had bought up large. So this is sort of where looking at saliva first really sort of, you know, we're collecting it anyway, and all of those samples that I listed earlier, all of the samples coming in were being tested for SARS-CoV-2 presence, also including the saliva samples. So we started sort of paying a bit more attention to those results because we were worried that we were just going to run out of nasopharyngeal swabs. And also these swabs we were using for research purposes, and we did not want to be adding to the supply chain issues for those who actually needed them for diagnostic screening. So hospitals, Quest, anywhere that were really sort of more informing actual patient treatment options, rather than, you know, us taking these swabs for research, which of course, you know, has a lot of important outcomes there as well. But of course, their most immediate need was making sure that anyone who needed to have a test or could have a test could do that. So while we sort of started to sort of scramble around a bit, you know, we contacted different 3D printers all around the community. We started looking into 3D printing design and what sort of considerations we would need in terms of meeting FDA requirements. And so we had a team of people actually looking into that and receiving sort of prototypes of 3D printed swabs. We had to start making our own VTM, so that's the viral transport media. CDC was really great about that. They actually published online like a recipe for your sort of make your own viral transport media. So we ordered all of that in, enough for sort of 10,000 tests, and just started furiously aliquoting that out. And then got to the point that even those tubes that we were using for that VTM, they were also starting to be in short supply. So it just, you know, that's quite a long piece there on these supply chain issues, but just really hitting home that these nasopharyngeal swabs were just so reliant on all these different little pieces of this puzzle, just because it's such sort of a specialized kit and tool that you need in order to take the swab. So just going on for the actual, I mean, I mentioned already the RT-PCR detection, and this is how we're actually detecting SARS-CoV-2, so detecting the coronavirus RNA in these samples to determine whether they're positive or negative. And so as we were sort of getting all this up and running, Chantal Vocals, who's a postdoc in the Grubar's lab here at the School of Public Health, she actually just started assessing sort of and really sort of analysing all the different assays that were sort of being recommended and used in different places around the world for SARS-CoV-2 detection. And the reason why she was doing this was because, you know, the CDC had released their N1 and N2 assays. So they're sort of detecting very specific regions on the SARS-CoV-2 viral RNA, and they were sort of providing these RT-PCR kits. But again, those were sort of assays that were made available for diagnostic screening. And again, we were wanting to sort of draw off the same reagents and assays that were sort of desperately needed by hospitals and diagnostic labs around the country. So we were the primers and probes, their sequences were made publicly available. We could order these in through IDT, and we just took a master mix, a lunar master mix from New England Biolabs, and we're just assessing the different available RNA targets that we could use. So we're looking at sort of the different ones being used by the China CDC, Hong Kong, in Berlin, and the US CDC, and just comparing detection in all of these, and just getting a feel for this assay in our hands to make sure it was as sensitive as possible for SARS-CoV-2 detection. And so based on all of this, even though we're comparing all of these different assays, we have gone ahead and used the N1 and N2 gene targets as recommended by the US CDC. As part of this assay, we do also detect, we test for RP. This is a human RNase P. And what this actually more acts as is this is actually an indicator of how good your sample type is. So when you're taking some sort of human material, be it a saliva sample or a nasopharyngeal swab, you're picking up human DNA as well. And so by targeting that human DNA inside your sample, it can tell you, especially for nasopharyngeal swabs, was it a good swab? Did it really get in there and sort of pick up a lot of material? Or as even CDC states on their website, that if it's actually below 35 CT, which actually means a very low or weak signal, this sort of indicates that the swab wasn't taken very well, that actually if you're getting a negative result for virus, you've also got quite a poor result for your human DNA, so therefore your swab probably wasn't actually of an acceptable quality, and that can also influence your results. So it's really there as a control of how good your sample type is. So moving on to look more at our study and what we have been looking at in terms of the nasopharyngeal and saliva detection. So we do have a preprint that went up on medRxiv in sort of mid to late April. The data that I'm sharing with you now is actually an updated data set. It hasn't actually been updated since, I guess, since April 20th. So it's still a little bit of old data now, but it isn't expanded as compared to the preprint that we have. So this is just sort of an overview of those who were enrolled in the study. So the sort of numbers that ended up in ICU, either on admission or during hospitalization. 24% of the individuals required ventilation, and also sort of even by April 20th, we'd already sort of lost 9% of our population. So what we did, so from these inpatients, this just shows the total number of sample types that we collected. So overall, we collected 210 samples so from our 85 inpatients, we collected 210 samples in total, divided between the nasopharyngeal and saliva samples. What's more important to look at is that from these samples, we actually had 122 sampling moments or samples that were actually matched. So from those 85 inpatients, we had samples that were taken at the exact same time. We had 61 nasopharyngeal samples and 61 saliva samples. And already what this shows is that when you look at these matched samples taken at the same time points, you can already see that of the 89 of these sets that were positive, we actually already had higher detection in saliva samples as compared to the nasopharyngeal swabs. So of these matching sets, 77% of the saliva samples were positive, whereas only 69% of the nasopharyngeal samples were positive. So when we also then looked at the level of SARS-CoV-2 detection in these saliva samples, what we also saw is we found a higher detectable viral load in saliva as compared to the nasopharyngeal swab. So we were getting stronger virus detection when you look at them overall. And then when you also look at the matched samples, those matching pairs, again, we were getting higher viral loads detected in the saliva samples as compared to the nasopharyngeal swabs. And this is just another way of presenting this. So this is the scatter graph showing on the x-axis the viral load in the nasopharyngeal swabs, and on the y-axis the copies, the SARS-CoV-2 viral load in the saliva. And with more of these dots, so each dot represents a matching sample pair from an individual at that time point. And with all of these samples falling, like a lot of them falling above the line, this is again just really highlighting that we were having higher viral load detection in the saliva of these inpatients as compared to the nasopharyngeal swabs. And while, you know, so in these grey areas actually show the samples that were positive in one sample type and not the other. So out of all of this, I mean, neither of these sample types is clearly perfect. So along the bottom, you have the samples who are positive in the nasopharyngeal swab, but negative in saliva. And up the side, you have the samples that were negative in the nasopharyngeal swab, but positive in saliva. And while, you know, that while there were instances where we only detected virus in one of the sample types, while 7 of these samples were positive only in the nasopharyngeal swab, 14 of them were only positive in the saliva. So again, showing that with this difference is that we were having better, sort of generally better overall detection in saliva samples compared to the nasopharyngeal swabs, with a false negative rate in the nasopharyngeal swabs of 24% and only a false negative rate of 12% in saliva samples. We then also just looked at all of these samples over the course of infection, course of infection, but also over the course of the hospitalization. So what we have along the x-axis are the days since symptom onset. So as individuals were enrolled into the study, we asked them some questionnaires, and that's also sort of figure out, you know, when they actually started experiencing symptoms. And sort of what you can see between these two samples is, between these two graphs is, so on the left we have the saliva and on the right is the nasopharyngeal swabs. And those samples that are from the same individual are joined by dotted lines. So those are their sort of longitudinal samples where we have more than one a sample from individuals at those time points. And you can sort of see, you know, you sort of have just a bit of a more clearer trend in saliva samples, whereas the nasopharyngeal samples are sort of all over the place, where you do have samples that test negative one day and then test positive the next. And while you see that we do have one instance of that in saliva, we had 5 instances of that in the nasopharyngeal swabs. And it's not just that, you know, they're negative one day and then positive the next, but if you sort of track some of these lines, particularly in the nasopharyngeal swabs, you can just see that what it's kind of reporting is though you've gone from like a high viral load to a low viral load to a high viral load to a low viral load. Whereas if you look at the saliva graph, you sort of just see the sort of more steady sort of trend and decrease, and much more consistent rather than sort of jumping up all over the place between positivity and negativity. So that, moving on from the inpatients, I just want to touch on the healthcare workers, because there's also been, it's a small number that we've had test positive, which is obviously really great. It's been really great for our healthcare workers, our hospital. It's been really reassuring that their PPE has particularly been working. These are the results from our first 8 healthcare workers, asymptomatic healthcare workers who did test positive. We are now actually up to 16 individuals who have tested positive, but we have an enrollment of about 650 healthcare workers. So, you know, only 16 individuals who are, you know, and again, these are healthcare workers who are on COVID-19 wards or have occupational exposure. But what I just really wanted to show with these results here, and firstly, what we're finding interesting. So the really important thing about our healthcare worker cohort is that these are asymptomatic individuals, and it's been hard to sort of study, you know, people around the world. We're looking like, you know, how do these testing and methods and sample types, it's the big question at the moment, how do they fare when you use them on asymptomatic individuals or pre-symptomatic? So what was really interesting is actually that our very first healthcare worker who tested positive, they tested positive in their saliva sample. They did not submit a self-collected nasopharyngeal swab, so all we had to go off was the saliva sample. And if anyone's not familiar with RT-PCR or qPCR results, the higher the CT value actually means the lower the viral load. So this actually means, so 33 CT, our cutoff that we were using is 38, the hospitals are using 40, but this just sort of means that there's very low viral load in this individual. So, and we first detected that using their saliva. This test result triggered their testing in a clear diagnostic lab, and so the next day they went off to the clear diagnostic lab, had their nasopharyngeal swab taken, because that's all what the clear diagnostic labs can do, and it came back negative. So you can imagine that there was a little bit of questions and concerns about us testing them positive in their saliva sample. So a couple of days later they came back and they provided us with both a saliva sample and a nasopharyngeal swab. And again, our saliva sample, when we tested it, or their saliva sample, came back positive, but the nasopharyngeal sample again came back negative. And then the next day they finally went back to the clear diagnostic lab, and that's when they got the positive signal. So especially being our first case, and especially using a sample type that basically no one else was using, this was just eventually really reassuring that this initial early detection that we got was then confirmed in a clear diagnostic setting. And this has actually been the case now for the rest of our samples. We've actually had a number of instances where we've only had the saliva sample, again triggering their clear diagnostic test, and again that's been confirmed. So we're sort of just trying to get a feel of, you know, how saliva and MP testing is really performing in asymptomatic individuals. And just to put sort of these CT values into a bit more of a comparison to our inpatients. So these are the saliva CT values from the healthcare workers in purple as compared to the CT values we're getting from COVID inpatients. So you can see that they are more on the lower end of detection. And one of the things to remember about the inpatients is that these saliva results are over the course of their infection. So you're going to have, you know, the higher ones are probably usually sort of closer to symptom onset, and as they start resolving their infection, you'll get lower and lower detection. But sort of just showing that these sort of results that we were seeing were still, you know, a low viral load, and probably maybe why they remained mostly asymptomatic. So we then just, you know, we wanted to also then sort of explore that variability in the nasopharyngeal swab collection. So I'm just going to flick back, and what I'm referring to here is sort of this variability that we see in the nasopharyngeal swabs, this up and down kind of, you know, negative one day, positive the next, that I had mentioned. And the first thing we sort of did was to compare, so I mentioned earlier about targeting this human RNase P gene and how that can be a sort of a testing control of how good your sample type is. So the first thing we did is we looked at sort of the variation in the human RNase P gene that we got between the different samples types. And what we found is that there was a lot less variation in the RP that we got when you tested saliva samples compared to the nasopharyngeal swabs. So again, so this is just the CT values, and with sort of 30, 35, 40 being sort of your weaker detection. So you can see there's quite a tail on the RNase P, just suggesting and indicating that, you know, the swab type is variable. The saliva sample type is a lot more sort of consistent between collections and individuals. And this is just another way to see this. So I mentioned that our healthcare workers, they were taking their own nasopharyngeal swabs. You know, they're healthcare workers, they're trained professionals, they do this a lot. And each of these different colors on this graph represents the same individual over up to 3 different time points. And you can even just see when you target this RNase P gene in their own sample type, how much this can vary between different sampling moments that even a healthcare worker takes it on themselves. So, you know, you can just see it sort of really low one day, really high the next, low the next day. So it's hard to get a nice consistent sample type when you're taking a nasopharyngeal swab, even for healthcare workers who are doing it to themselves and can probably feel how well they're swabbing or not. Now, this variability is not unique. This is also this paper is now from New England Journal of Medicine. This is very early on, back in March 19th. And this is exactly what I had already shown, sort of what we were seeing in our graphs, is if you look at the CT values, so the RNA detection in both the nasal swabs and the throat swabs, even in this study, again, is exactly what we saw, is that you have, you know, some samples that are quite positive one day, negative the next, positive the next day, negative the next, positive. So this just seems to be more of an inherent problem that you have when you're taking these NP swabs. And the other thing to remember about these in both our inpatient cohort and in this study here on screen now, is that these are inpatients. You know, they are confirmed cases. This is throughout their course of hospitalization. So it's probably unlikely that, you know, they've gone from positive to negative to positive, but rather, again, just the variability in these swab types. So I've already touched on it already, but one of the major limitations of, you know, our comparison of the saliva and nasopharyngeal swabs so far is that the majority of our cases have been from, you know, they're from inpatients, they're hospitalized, and your hospitalized individuals are having severe presentations of COVID-19. So even this graph from the Lancet Infectious Disease can show the viral load, how that differs between those with mild and severe disease. And so, you know, we are more likely to be in our inpatient population picking up higher viral loads. So therefore, you know, one of the big questions is still, how does saliva compare as a sample type in the outpatient setting? So in a larger cohort of asymptomatic individuals or early on in infection. What we have seen, though, is there have been some more studies being done where they look at both saliva and nasopharyngeal swabs, and we are seeing comparable results in outpatient settings. So you probably have all heard about the Rutgers saliva testing. So on, I think it's page 7 of Rutgers EUA application, where they have to present all their results, you know, they have compared results from 16 matched nasopharyngeal and saliva samples and found really concordant results between NP swabbing and saliva sampling. And this has also been the case in outpatients in a study published from California, one from Thailand, and also one from Melbourne, that even in, I mean, they're still outpatients, but they're not as severe as our hospitalized individuals. So it is nice to see that you know, a bit more support from studies in other places, and hopefully this will be continue to be expanded on. So overall, just to sort of summarize, is that the, you know, false negative qPCR tests do arise during the course of disease, but this is likely due to the timing, disease severity, but also that sample quality and the type of site sampled. Saliva is a viable alternative to nasopharyngeal swabs. We've found it to be as good as or better than in early hospitalization nasopharyngeal swabs, and it parallels the performance of NP swabs during hospitalization and recovery. So at the very minimum, it could be considered as an alternative time point to sampling. So this would really help immediately to relieve some supply chain issues and also your risk to healthcare workers. It is also a very important consideration for public health, because, you know, if we are finding high viral loads in saliva, you know, what does this actually mean for transmission, not only in the hospital, but also out in the community. So this is so that's sort of what we have found so far, and presented on, updated our data. Our paper is still under review, but this is obviously not just the end of our story. You know, the COVID-19 outbreaks, we all know that they're going to sort of continue for the time being, and they are going to disproportionately impact vulnerable societies. So for this, more testing options are needed. We need inexpensive tests, we need simple tests, and the tests need to be scalable. So for saliva, for example, this holds, you know, that can be an answer to a number of those testing issues, which could prove to have even greater benefits, especially in settings such as like low and middle income countries where your health systems are already under-resourced. So we are continuing to work with saliva, to continue to validate it as a sample type, to look into it. There are some, there's definitely some more development and validation steps still required. These include just, you know, understanding the risk of handling saliva samples. So if we are taking saliva samples from all over the community, if people start mailing them in, what is the risk of SARS-CoV-2 in that sample? If something was to happen to that sample, if it was opened up, what is the risk? There's also the question about the stability of SARS-CoV-2 RNA in saliva. So again, if you have some, you know, if there's delays in taking the sample, getting it to a lab, getting tested, you know, how long does that RNA remain stable in that sample for testing, and also at what different temperatures. I've been talking to some people, the curative people out in LA, who are also doing oral, they call it oral fluid sampling, but it includes saliva, and, you know, they're doing stability tests at 40 degrees Celsius because, you know, and even up to 50 degrees Celsius to sort of consider what, you know, LA may face during the summer. Another important consideration, and that we're looking into, is actually just reducing diagnostic time and costs. You know, if we can validate saliva to be a sample type that we could get a much faster turnaround time, this obviously has important implications in screening, so screening back to school, back to work sort of processes. And we also want to, with our experience with saliva and sort of understanding how to work with it, because it's not as easy or straightforward as an nasopharyngeal swab, but the fact that we are understanding how to work with it, you know, we are very happy to sort of validate and work with others who are looking at point of care or at home diagnostic platforms, just to make sure that the results that they're getting are as sensitive as possible. So as part of all of this, and as part of all of our ongoing work and sort of research strategies, one of the most important things we're keeping in mind is diagnostic needs. So it's you know, that's what we're keeping in mind, and we think a lot of other people should as well, is that research labs or anything, is that we shouldn't be pulling from supply chains that the hospitals are very dependent on. We also want to make sure that any test that's developed or for screening purposes is as sensitive as possible. So far, RT-PCR is the most sensitive way of SARS-CoV-2 detection. So anything that we're doing is we're trying to get it as close to that as possible. But even then, we still, you know, this big question is that still, even though that's the most sensitive thing we have right now, is that still sufficient for asymptomatic or pre-symptomatic infection? And there is also the question of, you know, what is the cost if we do have a decrease in sensitivity? So if you're, you know, if it means that we can get a test out there that can test a lot more people, but we do sort of lose the ability to detect sort of lower viral load, where you might have then people being getting a false negative result because you're not able to detect that very low viral load, sort of what is the risk of that? You know, if it's a healthcare worker going into a hospital or someone going in to visit, you know, a grandparent in a nursing home, that could carry important implications. Whereas, you know, if it's something through governments, just sort of trying to get more of a handle on the extent of the current outbreak remaining, maybe sort of a lack in, you know, missing a few of the positives is okay if it means that you can just screen a whole lot more people more quickly. We're also keeping in mind sort of the costs involved in this. one of the things, especially sort of with the Rutgers test, is that they involve very specialized tubes. They contain buffers in them, and these tubes are at the moment between $9 and $15. They're also on back order, and the big question here is, are these actually needed? I mean, so the cost of those tubes, put them up with the cost of tubes that you need if you're taking blood draws. The sort of collection cups or little tubes we're using are between sort of 10 and 30 cents a piece. But, you know, suddenly if hospitals and healthcare systems around the country have to start ordering these tubes at $12 or $15 a piece, that's, you know, really also limits their testing capabilities. And so, and then with those testing capabilities and strategies, one of the interesting things that we've been thinking of more recently is just sort of how to do those. You know, do you test a larger number of people less often? Do you do smaller tests more often? And sort of planning those testing strategies based on maybe your knowledge of what the prevalence of your outbreak is in your community. So the likelihood of, you know, how many positives there are actually out there, and if you should be testing more frequently or not, or making pooling strategies. So we're still thinking a lot about these things. We've still got a lot of work to go, and this has certainly been it's been an incredibly massive team effort. So many of these people on the slide alone I had not even heard of, let alone seen or spoken with prior to this, and now, you know, we talk very, very frequently, all working together. It's been incredibly inspiring throughout this whole outbreak, just seeing just so many people just drop everything and respond to the urgent need and help each other out. And, you know, it's not only, these are just people who we're working with and talking with here at Yale, but, you know, we're meeting with people in academic institutes, we're meeting with people in industries, we're meeting people who, you know, and I think in a lot of research settings, you might not just have very open and frank conversations with, you know, sometimes you're like, oh, I've got kind of a good idea, I might want to sort of develop this for myself and, you know, see what I can find. But it's been really great to see everyone really, really come together and being really, really open and honest with all of their research, and just really try and, you know, instead of us all reinventing the wheel, to share what we already know so that we can all make, you know, a lot more, you know, bigger steps forward. So, yeah, a lot of acknowledgements there, and I am happy to now take any questions.
Thank you, Anne. That was a brilliant talk and a very elegant study. Thank you. And clearly, you're not the only one who enjoyed your talk, because there's a lot of activity in the Q&A channel. Okay, so let's dive right into the questions. So let's see. So in your study, you, I believe, used quantitative RT-PCR as your detection strategy. What about isothermal amplification methods like LAMP?
So LAMP is an interesting one, and LAMP comes up often. I had actually not heard about LAMP. I do a lot of qPCR testing in my life before, my research before COVID, and it was actually only just before COVID that I had actually started hearing about LAMP, and we sort of started thinking maybe that would work for that. Generally, people are hesitant about LAMP because of its sensitivity. There was one of the, there's quite a big preprint on medRxiv, but then they show the results that they were finding with LAMP were only comparable to about, the lower limit of detection of LAMP was about 29 CT on RT-PCR, which, you know, ours is 38 and the hospitals, they're using 40, we just are using a stricter cutoff for ourselves. So they were missing, I mean, and as you saw, all of our healthcare workers would have been below that. So this is just one thing that we were just really trying to keep in mind, is that, you know, still compare RT-PCR so far for us is the most sensitive thing. So if people are developing LAMP assays or exploring them or trying to validate or optimize it, it's sort of, you really need to keep that lower limit of detection that we have of RT-PCR, because again, it comes down to, you know, what are the implications of then the false negativity that you're going to have through an assay that isn't as sensitive as another available assay. So I think that's really, yeah, there's been an interesting one that's come out from, but yeah, so just keeping an eye on those and just seeing how, just really comparing their sensitivity as to RT-PCR to get a feel of them is really important.
Cool. While we are on sensitivity, here's another question. I think this was from, was it from Loren? I don't know. So it's pretty well documented that there is a variation, person-to-person variation in the composition of saliva. Right? There's a pH difference, and there's calcium-magnesium difference. Did you find all this to affect your PCR results?
So, okay, yes and no. It's very, very true that sort of there's a massive variability in saliva samples. And for us so far, it's been more as you encounter those saliva samples and realize there's definitely ones that are thicker, there's definitely ones that are stickier, there's definitely ones that are stringier, there's definitely ones that have interesting particles in them. And so it's more just doing your upfront work before you put it through your RNA extraction to make sure that as it goes through, you know, you're accounting for that. You know, we do have a couple of instances where there's obviously been too much protein in the sample, so you have a bit of bead carryover with your magnetic beads, and of course if your magnetic beads are stuck in your RNA extraction, that can interfere with your RT-PCR. So there have been a couple of instances, yeah, especially compared to the nasopharyngeal swabs, which are very straightforward. We've had to sort of just re-extract and just, you know, add a little bit more proteinase K to break down those samples and get those results. So, I mean, it does make it harder to be more of an automated process because it does require a little bit more attention per sample rather than just being able to sort of put it all into liquid handling robots. But, you know, it's something that that's one thing, it's something that we're aware of, so we've been able to keep an eye on, but it's also what's really important that anyone else who's setting saliva sampling up is also aware of and tries to keep in mind when developing these assays.
Cool. So a related question to sensitivity, and this comes from Kim. Were there any consistent errors identified in self-saliva collections, and did that impact detection?
Any consistent errors? No. I mean, you can't, you know, you can't really screw up a saliva collection. I mean, what you see is what you've got. So as long as you're getting material into the cup, yeah, you've got samples. So,
well, I guess the question is, were there any errors in the results? That's what I interpret with self-collection, so samples that were self-collected.
Not that we're aware of.
And a related question, this comes from Ben Arthur, is, okay, how much variability is there in the measured viral load if you repeatedly did your RT-PCR on the same sample? I mean, this goes for both nasopharyngeal and saliva samples.
It's incredibly consistent to the point where, because we use, say, a cutoff of 38, and every now and then our N2 will be sort of 37, and our N2, the M1 will be 37, our N2 will be like 38.02. So we're like, well, to us, this kind of looks positive. We will repeat the same RT-PCR and we get very, very consistent results. We also get very inconsistent results if we repeat the extraction, including after freeze thaws of both whether you're doing freeze thaw of the sample and putting it all the way through, or freeze thaw of the RNA. We've also, there was one instance where a plate was left out, a plate of RNA was left out on the bench overnight rather than going into the freezer, and all those samples were retested and they were still the same, roughly, you know, within like 0.0, you know, very, very close to what they were when they were run fresh. So our results are very, yeah, reproducible.
Speaking of, what about salivary RNases? Have you thought about salivary RNases chewing up your SARS RNA?
I can assure you that that doesn't seem to be this is my thing. That's what I think. That's what with the spectrum tubes, Rutgers, what the hospitals are worried about. Why they think that we need to have these expensive collection devices and everything. Generally, it might take about 12 hours between collection and our testing, just because of the hundreds of samples we're receiving, processing them all, getting them to RNA extraction. So it is about 12 hours between collection. We are doing stability tests at the moment where we just leave these saliva samples at either room temperature, 30 degrees, 4 degrees, with nothing in them, and still over, you know, a good few number of days, we are getting very consistent results. So I don't think there's any concern at all about RNAs as chewing up SARS-CoV-2 RNA. It is remarkably stable.
Cool. And okay, here's a question for me. Have you done this comparison between nasal swabs and saliva at different time courses of the infection?
I mean, but I guess that's the thing. I mean, yeah, these are all hospitalized individuals. So, I mean, yeah, so I guess, yes, because these samples are taken throughout the course of infection. So soon after infection, follow up, you know, up to sort of 20, 30 days afterwards, our asymptomatic individuals. So, yes.
And then now we have a question from Wyatt about your saliva collection media. Could you provide some more information about the transport medium used for saliva collection?
That's what I'm saying. We're not using any. You don't have to. You just simply spit into a cup. We don't do that. And we're not sure why others are doing so when it adds to sort of the cost. It makes it easier to prepare it, but we're not using any. We don't need to.
And then there's a question from Brian. Are the viral loads highest right after waking up? Should swabs also be conducted in the morning? Or can you say variation with the...
That's a really, really interesting question. I usually, I've worked with saliva previously, but just from like asymptomatic carriage from healthy individuals who just, you know, we get saliva at any time. I'd never actually heard of first morning saliva until working with these inpatients. And yeah, the idea is that's going to help detection. But all of our asymptomatic carriers at the moment, they just collect their saliva when it's useful for them. They don't do first morning, and we're still getting it. You know, we haven't done a direct comparison between, like, you know, getting our healthcare worker to like wake up and, well, first of all, we need to find one and make sure that they're all positive, or even our inpatients. We haven't done the whole, you know, wake up in the morning, give a sample, give another sample 6 hours later. We haven't done a direct thing like that. So yeah, it's hard to say.
Cool. The next question, I'm sure you've heard this. This is from Kim. Have you tried detection without RNA extraction?
Yes, we have. We're working on that now. So we are, yeah, that's our thing. That's what we want to do. We want to break away from the, you know, the supply chains, the cost, the time that's required for that. That is what we're working on at the moment, is to do an RNA extraction free method, which means that we can almost essentially go straight to RT-PCR, which means that we could get results within about an hour and a half, 2 hours, which, you know, in terms of that's 93 samples on a plate. It's a much faster turnaround time than a lot of the other tests out there.
Cool. And then there's let's see. Still, there's a question about freezing samples. I'm not sure if you've answered this. If you have, pardon me. Did you freeze samples, or otherwise did you use any preservative in your saliva samples?
So again, no preservation materials in the saliva. It's not needed. And again, yeah, so I said that we've done the freeze thaw. So, you know, we test our samples when they come in fresh. Sometimes we've had to repeat them, or we're using them for, you know, other validation work. We can freeze thaw them multiple times and get essentially the same. There's been like no decrease, no drop off. Our healthcare worker cohort now, so what happens is if they get signed off because they're obviously infected, they stay at home, and we've got them just sort of collecting their saliva throughout the course of their 14-day self-isolation and putting it in their at-home freezers as a way of just, once they can come back, we can sort of see what happens over their course of infection.
Cool. Okay, and then Here's another question. This is from Loren. Are there any clinical correlates of patients with higher nasal swab viral load than the viral saliva load? Like, do they cough more? Do they have a high fever? Or
so I haven't looked into it specifically myself. I was just talking to Akiko Iwasaki this morning. She's been, her and her lab have been looking more into sort of like the correlates, and we didn't go into it because it was on a different meeting, but she did mention that when they were doing all of their analyses, the viral loads that we were finding, and this is actually really, I think, a very important consideration, the viral loads that we were finding in saliva as compared to the nasopharyngeal swabs were much more highly correlated with sort of all of the sort of clinical outcomes. And I think this is a really important thing going forward, because now a lot of people are starting to look into therapeutic options, you know, vaccine trials, and the gold standard is a nasopharyngeal swab, you know, testing. But actually, if, you know, the saliva sample is going to provide a much more consistent sample type, and if, you know, from what she's seen with that data, if that is more correlated to outcomes, then I think that's actually something that's going to have to be really important that we stress and keep in mind. So, yeah.
here's a very interesting question, and this comes to us from Kannan. He wants to know whether, based on your experience, do you think this would be sensitive enough to test asymptomatic carriers? The viral.
I mean, so that is, I mean, this is nothing. That is what we're doing for our healthcare worker cohort. And what is really interesting is that a lot of these are testing positive first in their saliva sample as compared to the nasopharyngeal swab. So, I mean, it's almost like at the moment it's what we've got. Again, you know, RT-PCR detection is our most sensitive assay that we have. And, you know, so now it's like, will saliva give us a more reliable type? So we are seeing, yeah, we're seeing earlier detection and more sensitive detection, whereas like a nasopharyngeal swab might be negative, but the saliva sample is generally around sort of 33, 34 CT. So for us, it's hopeful, but yeah, we do need a bigger, you know, N than just 16. But at the same time, we don't wish any more infections on our healthcare workers than they already have. So it's been a little bit tricky way to study and explore this.
Okay, on a related note, this is saliva. Have you tried sputum? Because then that would be a little deeper down, so you could get a...
Yeah, I mean, sputum, sputum's already on like the CDC's list of recommended sample types, but, you know, sputum has a lot of its own challenges. So sputum is a lot thicker, it's a lot harder to work with. You're also going to be getting it from probably a lot sicker individuals. It carries a lot of risk because, I mean, we are just asking people to pull saliva in their mouth and gently expel it into a tube. Sputum, you either have to cough up or you have to have extracted from you, which brings you back to all the risks related to your healthcare workers or anyone in your vicinity. If you think about asymptomatic infection, I mean, you know, one of the trademarks of COVID-19 is that it's sort of, you know, a dry cough with very few nasal secretions. So, you know, for most of your asymptomatics or mild cases, is there even anything to really bring up from your chest, you know? And so far from what we're seeing is that, you know, if we're still having good, robust detection from saliva, which is correlating to sort of patient outcomes from saliva, I think, you know, there's no need to start working with an even harder and more risky sample type.
Loren, do you have anything to ask? Would you like to add?
Yeah, I'll jump in here. So, you know, we briefly talked about the effort going on here at Janelia to make LAMP a lot better.
Yeah.
So just wanted to give a shout out to that team that they can get CTs up to 35.
Yeah, I just saw that, and I think that's great. I think considering the other one who published like 29 just caused me a lot of concern, but I mean 35 is, yeah, it's really good.
Yeah, and they have some more questions for you. Do you know anyone that would be willing to send validated saliva from clinical samples that they could use?
We could be. We do actually have, we do have a biorepository request where you can submit a sort of application for both samples and data, and then that gets reviewed by the Board of Governors. Unfortunately, yeah, so it depends on volume required. We, because we've already reviewed sort of about, I think, over 20-30 applications for specimens from the biorepository. But they also, in the end, ended up playing an incredibly important part for the FDA EUAs by CLIA diagnostic labs. So a lot of our saliva and nasopharyngeal samples we were able to share with the likes of the Yale New Haven Hospital Diagnostic Lab. We shared them with the JAX lab, just so that they could get the FDA EUA as well, which means that, you know, around the state we can start helping to meet testing demand. But it means that our supplies were greatly diminished. So I think it's more, it'd be great if we can, if you very welcome to submit a request and sort of what volumes you need, how many you're thinking of, what sort of things you're looking for, and then that can just sort of be assessed versus what's left in our biorepository at the moment.
Yeah, I mean, it sounds like your samples are already getting pretty taxed. I don't know do you know anyone down near us that might be testing saliva? I mean, we're getting some samples from Hopkins, but I think they're pretty reliant on NP swabs and aren't doing saliva much.
So Chris Heaney's lab at Hopkins, they do saliva for antibody testing. They're using Oracle sponges, and they're also finding that they don't have a huge amount left over, but I know that they're collecting and testing saliva. And then otherwise more and more hospitals at the moment are trying to get their FDA EUAs in to be able to, or their CLIA applications so that they can test saliva. So you might find if there's any sort of hospital diagnostic labs around you, they may have started collecting already both saliva and NP swabs from patients as a way to sort of get their matching set that they need. And they might actually have surplus that they might be able to share.
Okay, great. Maybe afterward, can you just send me an email with those names and I'll pass it on to our team here?
Yeah, sure.
Okay, thank you.
I just realized I missed a question from Kim. Sorry, Loren, were you going to ask something?
I think I was going to ask that same one, so you go.
Go ahead, you go ahead, yeah.
Okay, so this is also from the LAMP team here. You know, so obviously Janelia is not CLIA certified.
Yeah.
We are just a research institution. But you know, if we jump through about 500 hoops, we can you know, test saliva. What requirements did you guys have, and how easy or hard was it for you?
It was relatively easy for us because, of course, we're also not. So the lab that we're doing all of our work, we're not CLIA certified. We are just also academic research institution. We just needed to run it by EHS and just have them on board, like our local EHS, just making sure that our labs were fully certified by them, that, you know, we'd all been over protocols together and making sure everything was in place. So yeah, I mean, the only difference is that at least with those tests, if they're a CLIA certified lab, then that's actually, you know, an official test result. So say for our healthcare workers, when we're screening them, that's why they have to go to a CLIA lab. You know, we've got a result for them, but they can't act on it because it's not an official CLIA test, but we can inform. But yeah, contact EHS. I mean, I'm sure there's actually other people probably all around the country who are sort of now, you know, like, hey, we've got an RNA extraction machine, we've got a qPCR machine, we can be doing these ourselves. But I think clearing it with EHS is always the best thing.
Yeah, I mean, we already found out. I mean, we'd have to do a big IRB. I mean, it would be a production for us.
I mean, yeah, that's the other thing. I mean, like if you're testing any sort of samples or patients or anyone, I mean, like, throughout all this, you know, none of us have been tested. We haven't tested ourselves or each other because that's not part, you know, you have to have the IRB
Right.
for whoever you are testing and make sure it's all part of the study and very officially done. So yeah, we do have the IRBs in place for making sure, yeah, to test those samples.
Okay. Let's see, another good one. So if we want to get to super high throughput, have you guys tried pooling?
That we have. I just collated my results this morning. So yeah, no, we're also looking at that, particularly again, I think it comes to the question and, you know, once especially schools start back and if we start screening all the students as they return to campus, you know, if you can just do sort of pooled testing, especially when your maybe your predicted incidence will be a bit lower. Yeah, so I tested pools of 5, 10 and 20 the last couple of days, and it's looking really promising, even up
Wow.
to even with 20 individuals. So yeah, that's hopefully
that's amazing.
yeah, that's my plan for tonight, is to actually draw up the report and tables and everything on that. So
Wow, okay, that's really hopeful. Okay, fantastic. Sarada, do you have anything more?
I think we've covered pretty much all the questions on the board here.
Yeah.
And I asked mine, yeah.
Yeah, and this was amazing.
yeah, no problem. Happy to, yeah, and if anyone else wants to reach out at all, has any other questions, our protocol, we've just put up our protocol for saliva collection and testing as a Google Doc available online that we're happy to share with anyone who's interested in what we do. Any other little just tips and tricks we have for working with saliva, that's in there. So always just happy to share that as well.
Okay, yeah. Can you just toss that in that same email then, and then we'll get that
we'll put it up,
to the right people.
Yeah, sure, no problem.
Awesome.
Great.
It's really exciting.
Thank you, Anne. Thanks for your time and thanks for sharing your work with us today.
Yeah, no problem. Thank you.
Thank you.
Yeah, stay safe. Keep
Bye.
saving us.